We'll let you get started. And I do talk a little bit about SNOCAP, but I'm sure you'll let us know even more. So
Yeah.
with that, I'm going to go ahead and introduce. If all of those tuning in could keep their mics muted, that would be great. My name is Cynthia Snedden. I am the Education Development Coordinator in the Oncology Clinical Research Support Team, so in the Cancer Center. Our speaker today is the director of SNOCAP. SNOCAP stands for State Networks of Ambulatory Practices and Partners. Our speaker is also chair of the Practice-Based Research Network Collaborative, which is the overarching name of the collaborative of which SNOCAP is a part. This collaborative is an affiliation of practice-based research networks in Colorado that join together to improve communication, facilitate joint research projects, and share research staff and resources. Our speaker is a professor of family medicine and vice chair for community in the Department of Family Medicine here at the University of Colorado, and is director of community engagement for CCTSI. Our speaker completed his undergraduate degree in medical school at the University of Kansas, his residency at the Medical University of South Carolina in Charleston, and a faculty development fellowship at the University of North Carolina, Chapel Hill. His passion is to improve health in partnership with communities, patients, and clinicians and their practices. Okay, my screen are you still seeing, am I still sharing screen? Okay, not sure what happened here. It's my privilege and honor to welcome Dr. Donald E. Lease. Thank you, Doctor.
All right. Thanks so much, Cynthia. It's great to be with you all for this Lunch and Learn. And Cynthia, I'll share my screen as soon as there we go.
Okay.
All right. Let me get my slides pulled up here. And put this into presentation mode. Great. Okay, hopefully everybody can see that just fine.
Looks good.
All right, great. Well, thanks once again for the invitation. It's really great to have a chance to talk to folks from the Cancer Center and others about our SNOCAP, Practice-Based Research Network infrastructure here in Colorado. As Cynthia mentioned, I'm a professor in the Department of Family Medicine. I'm fortunate to hold an endowed chair that helps to support this work. We also get some core funding that also comes from the Department of Family Medicine and also from the Accords Center on campus. So lots of work that goes into keeping this going. My comments today will probably run about 30-35 minutes. Please put any questions that you might have into the chat. And once I get done speaking, I'll be happy to address those as they come in. So with that, I will go ahead and jump on in. So as Cynthia mentioned, SNOCAP stands for State Networks of Colorado Ambulatory Practices and Partners. This is our logo, which we're proud of. We refreshed this about, I don't know, maybe a year before the pandemic started, and it's a great brand for the work that we do. So today I'm going to talk a little bit, I want to give you a little bit of a background on what practice-based research, particularly in primary care, is all about. Really, this has been a national and now international movement of practice-based research and networks that help to support this kind of work. So I'll talk a little bit about that. I'd like to give you a little bit of an overview about how SNOCAP's organized, how that infrastructure works, talk about what we aspire to, kind of the principles that we think about as we're doing this work, give you just a little bit of a thumbnail of what we've done in the past, and how we like to connect and collaborate with folks because while we certainly have some of our own research that we pursue through SNOCAP, it's always great to be able to work with other partners and bring the innovations that they're researching to our practices as well. So what's the story on primary care practice-based research? Well, we really think about this as research that takes place in ambulatory settings where most people get their care. I've got a little slide on that. I think that's coming up next. And this really arose, the notion that practice-based research was going to be important really arose in the 1970s. And this sense that for folks out in practice, folks in these ambulatory settings, the research work that was being done in academic health centers like our own wasn't always exactly relevant to the folks out there in practice. You know, there were things at that time that were, you know, this was really before the days of evidence-based medicine. But, you know, there were things like, you know, anybody that shows up to an office-based setting with a headache, you know, you really should consider a CT scan. And that actually became a topic of some early practice-based research to actually investigate whether or not that was necessary. So there was a lot of interest in doing this kind of work back in the 1970s. And as I'll mention, that's carried forward to today. We also like to address questions that arise through daily medical practice, often in a primary care setting. So that's one of the things that we try to do on a regular basis is connect with our practice partners, connect with people in the communities where they're doing their work. What are the issues that are coming up? And that oftentimes leads us to really important work. And like a great example of that is work that we've done around opioid use disorder. That was an issue that came up at one of our statewide convocations, really about 7-8 years ago now. Practices and community members said, yeah, we've got a problem that's developing. This was before it hit any of the national media. And that has led to a continuous stream of funded work trying to help our practices address that issue. And the cool thing about this is that this is all done in partnership with folks in primary care practices working together to answer these questions and improve the quality of their care. And it really spreads out the effort and allows us to increase the end of the work that we're doing. So this is that slide I mentioned where about, you know, primary care and the outpatient setting being where most folks actually receive their care. So this is something that was done by one of our senior faculty who's still with us here in the department, Dr. Larry Green. And this was published in the New England Journal back in 2001. It's been updated several times since this, but this is kind of still the classic analysis. So the idea here is if you take 1,000 persons out in the community at any given time, you know, about 800 of those folks are going to have some kind of symptom. Oh, I've got a sore knee, or I've got a cough, whatever that might be. Of that 1,000, there's 327 roughly that consider seeking medical care. 217 will actually act on that consideration and go ahead and visit a physician's office. 113 of those actually go to a primary care physician. 65 might go to a complementary alternative medical care provider. Now the numbers are starting to get much smaller. 21 are actually going to get seen in a hospital outpatient clinic. 14 might get home health care, on down the line until we get to that less than one that's actually hospitalized in a place like the University Hospital or Children's Hospital. So the need to push research out into these community settings is really, really important, so that we make sure that the research that we're doing comes from population of folks that are out in the community, and we're not going through this selection bias of folks that actually end up in a place like across the street. The other thing that's really important is this business about, and this is a paper that was done by one of our former colleagues, Dr. Jack Westfall, along with some other practice-based research network colleagues from around the country, that came out in 2007. Practice-based research really being like the blue highways of the NIH and their roadmap at the time. I don't know how many folks remember Blue Highways as a novel by William Lease Moon, but a really cool book that talked about kind of the back roads of America, and that's where sort of real life was happening. Well, that applies to practice-based research as well. And the second bullet point here, in order for us to really address this, that was identified by Dr. L'Enfant years ago now, of how long it takes for scientific discoveries to enter day-to-day clinical practice. Practice-based research provides an answer to how we can shorten that, both in terms of the original research, but also in terms of, looking at implementation and dissemination out into real-world practice. Practice-based research networks are great vehicles for doing that. So the history of this work, I mentioned there was a big push to start this back in the 1970s. There were some early pioneers. The Dartmouth Co-op up in the northeast part of the country was one of these. FMIS, that stands for Family Medicine Information System. That was Colorado's version of the Dartmouth Co-op. And then ASPEN, the Ambulatory Sentinel Practice Network. That was the first national primary care research network that was also run out of Colorado. So Colorado's been at the forefront of this work from the beginning. And those early practice-based research networks dug into all kinds of interesting questions. I mentioned the headache study. They looked at whether or not antibiotics were required for otitis media that was being seen in primary care. Lots of really important stuff that those groups did, often, with just a shoestring's worth of funding. So as we got into the late 1980s and early 1990s, this was when my career was first starting. AHCPR, the Agency for Healthcare Policy and Research that became the Agency for Healthcare Research and Quality, began to start funding PBRNs. They developed some funding that they put out through RO3 mechanisms and others to promote the development of PBRN infrastructure. And that really catalyzed the founding of a lot of practice-based research networks that continue to this day around the country. And so that was really important. They also began to partner with some other NIH institutes. One of my first federally funded grants was a joint AHRQ National Cancer Institute grant to promote cancer screening services in our practice-based research network where I was at the time in Michigan. So that was really important stuff. And then in the 2000s, AHRQ again began to release more infrastructure awards. They started funding a national center for practice-based research and grounded an annual conference, which continues to this day, that usually occurs in Bethesda in June of every year, where folks that are doing practice-based research from around the country come together to talk about how to move the work forward. In the 2010s, AHRQ began founding PBRN consortiums. And what these were linkages of practice-based, usually state-based practice-based research networks around the country. We're part of one of those that continues to this day that links us with practice-based research networks in Oregon, Iowa, Wisconsin, and we've actually extended it into Canada. So we collaborate with 2 practice-based research networks there as well. And 2020s, AHRQ continues to be at the forefront of this work. There's more PBRN funding that's coming down the pike from AHRQ. And I think that practice-based research in general has now caught the attention of NIH institutes, and PCORI has their own PCOR net that's out there. And I think we've been a part of, Russ Glasgow has an Implementation Science Center grant that we've been a part of because NCI has been interested in this work as well. So fortunately, the work continues. This is just the AHRQ PBRN website that's got a lot of good information. AHRQ maintains a PBRN registry as well that you can go to. And if you want to see if there's a practice-based research network in any part of the country, you can go there and usually find the information and how to get in touch with them. So again, the purposes of practice-based research, we really work on population health, closing this gap between what's in the literature and what's actually being delivered. We like to think of ourselves as being in the business of making sure that care delivery at the primary care level is very high quality and high level of excellence. So quality improvement is definitely a part of our work. This notion of understanding the local culture and how that fits in with people's understanding, health literacy, diseases, and decreasing health disparities. That's a really important aspect of our work because primary care practices are often distributed in rural areas, in communities that may be experiencing significant health disparities. Again, PBRNs are a great tool for addressing health equity and health disparities issues as well. And then connecting practices with researchers. You know, the folks that we work with out there in practice, they view this as a great way to stay connected with the science of medicine and to be part of a learning community about that, and to collaborate with peers and folks on this campus around improving practice and staying abreast of the latest innovations. So that's an important aspect to this as well. You know, core principles that we aspire to, we really think of practice-based research as an important form of community engagement. And what I mean by that is our practices that we work with, there's certainly a community. There's a community of practices. And when I get to talking a little bit more about SNOCAP, that's part of why we have 5 different practice-based research networks here in Colorado instead of 1, because practices like to be affiliated with practices that look like and do this work with similar populations. So the community engagement at that level is important. And also practices are embedded in their own local communities. And so that's also an important aspect. And many PBRNs these days include community or patient advisory councils that really help to inform that work. And that SNOCAP is no different, as I'll mention in a bit here. We also think it's important to have a mixture of bottom-up versus top-down research and questions that are coming up. So we certainly do our share of studies that, based on funding announcements that come from NIH or HRQ or PCORI that are a little bit more top down, but we always try to mix that with questions that are coming up from our practices. And even the top-down stuff, we try to make sure that it aligns with priorities that we hear from our partners in practice. So that's also a really important aspect. And then lastly, this last bullet, this is something that I usually make sure that when I'm talking to folks on campus that are interested in doing work in one of our networks or with SNOCAP as a whole, that one of the things we try to make sure that every study or project that we do leaves that practice in a better place. So, they might learn about some new innovation. They might get an improvement in the care that they're delivering. Their cancer screening rates might improve. That's a great example. We've done a lot of that kind of work. So they're getting something out of it that's actually improving the care or improving their practice. Most importantly, though, is that we're not doing any harm to the practice. So we work really hard as we're designing studies and as we're collaborating with folks who are designing proposals and that sort of thing, to make sure that the study is designed in a way so that when it gets carried out in that practice, it's not going to impede the flow of patients. It's not going to result in any financial losses. And that at the end of the day, when that project is done, the practice is going to be able to say, yeah, we were able to do that in a way that didn't impact our care negatively, and it impacted it in many positive ways. So that's really important as well. So having said all that, why would anyone really want to do this? Well, this is a question that we periodically like to survey our practices and find out, why in the world are you doing this? And we had the opportunity with a MPH student this spring who was interested in doing her capstone project with us. And so she surveyed and did interviews with practices here in Colorado, but we also included some of our partner consortium practices outside the state of Colorado. So we had a sample of 44 practices in total from 5 different networks. And we found, there's probably some response bias here, but this is pretty consistent in terms of a snapshot of what you see over the years in the literature about why practices get involved in this kind of work. So first thing, it's beneficial to their patients. That always comes out. This work they feel like is improving the care that they're delivering. It's beneficial to the future of their practice, helps them stay current, make sure that they're continuing to be relevant to the patients that they're serving. The research topics that are being addressed and proposed, that's really important, and folks feel like that we're in alignment there. And God bless these folks. A majority felt like, gosh, they'd like to get more involved. Honestly, sometimes we try to limit that a little bit because we don't want to burn our practices out. But there definitely are practices out there that every time we have a study idea or proposal, they raise their hand. So that's really special, and we're appreciative of that kind of enthusiasm. Some other findings from that work, a majority agreed that, again, this has been important for their practices improvement. I really like this lower one here, that the work that we're doing in practices helps spark conversations in their practice about how to improve the quality of their patient care. So that's a really important piece of this work as well. That's actually driving conversations at the practice level. Why do they stay involved? This is some of the interview responses here. It's a way to make true change that's geared toward the real work of family practice care. They believe in the mission of partnering to improve care and this partnership between clinics and academia. This comment about for some of our practices are actually residency practices, so community residencies, gives them a chance to see how they can get involved with this kind of work in the future and how important it is to primary care. And then finally, our local PBRN is great about helping us identify needs for improvement in our clinic. So that's a really important aspect too. And just to mention this degree of partnership, one of my colleagues who used to run the Oregon Rural Practice Research Network used to like to say that they always knew when they had kind of made it in with the practice when one of their staff or he himself could walk in the back door of the practice and everybody would be like, "Hey, LJ, great to see you. Thanks for stopping by. You know, you're not a stranger." And I'll talk a little bit about how we organize our infrastructure to promote those kind of relationships. So let's transition a little bit to talking about SNOCAP and how we're put together. So SNOCAP is an umbrella, a consortium, if you will, of 5 different PBRNs here in Colorado. The fact that we're under this umbrella really allows us some economies of scale in terms of how we coordinate and collaborate. It allows us to work together on projects where that makes sense, while at the same time allowing the individual networks to carve out pieces of work that may be really important for their particular practices and their particular populations. All of our PBRNs have their own staff, so a network director, sometimes an associate director, and PRAs or other folks that are affiliated with them. And our reach is about 280 practices statewide across all 5 of our networks. So these are the names of the member networks in SNOCAP. So Bighorn is our network that works with small to medium-sized freestanding primary care practices. When Bighorn was founded, the mantra was that these are more independent practices. More and more of them over time are affiliated with larger systems, but the key feature of Bighorn is these practices usually have a lot of freedom to make their own changes, a lot of flexibility in these practices, so it's great for innovation type work, and most of Bighorn practices are kind of distributed along the Front Range. CareNet is our practice-based research network that is focused on working with community health centers. And CareNet also has a geographic little footprint down in the San Luis Valley where we work with practices down there. CocoNet is our pediatric practice-based research network that's led by pediatricians. High Plains Research Network is the Eastern Plains. So every county that is east of the Front Range, any practice that's in that geographic footprint is considered a member of High Plains Research Network. And then PeachNet, which is our newest practice-based research network, started up about 4 years ago. That's our Western Colorado practice-based research network, and it's staffed and run by folks that live in Western Colorado, but have appointments and such with CU here, CU Anschutz. And this is a picture that was taken right before we went on lockdown of all of our network directors. So here's the map that gives you an idea of the location of our practices. You can see we've color coded these, and a lot of concentration of CareNet and Bighorn and CocoNet practices along the Front Range corridor. And you can see how PeachNet, and that's the appropriately colored orange pentagons, and the green diamonds for High Plains, that their geographic focus as well. So as I mentioned, each of our individual networks have their directors, but we also have a director for SNOCAP, which is me. We have an associate director, Mary Fisher, who would be with us today, but she's out on maternity leave. And the third bullet here about our field team staff, this is really an important feature, and it gets back to that piece of kind of being able to walk in the back door. So we hire research staff from local communities that are embedded there. So Kristen Suter, who is one of the High Plains Research Network field team. She lives in Merino, Colorado, which you probably never heard of Merino, Colorado, but it's kind of between Fort Morgan and Sterling, a small town. And she works with the practices in Northeast Colorado. They all know Kristen by name. She knows the folks in those practices. And so when it's time to implement a study in those practices, Kristen gets funding from the study, and she's oftentimes the one that's really the boots on the ground going out there to implement that project. That's just one example. We also have additional project staff that are here on campus that we work with, faculty and others that have expertise in survey design, qualitative research methods, and biostatistics support as well. I mentioned community partnerships. So an important part of our work is also our work with patient or community advisory groups. 4 of our networks have existing standing patient or community advisory groups. And these are some pictures of some of the folks that are members of those. So our High Plains Community Advisory Council. This is a picture from when, and we like to take these folks with us to travel. So High Plains Research Network actually took some of their Community Advisory Council to a NAPCRAG, which is one of the research meetings that we present at frequently. They were meeting in Puerto Rico that year, so they took them along. The next picture is community folks from CocoNet that attended the NAPCRAG meeting in 2018. I think that one was, I want to say Toronto. We had then next picture is our CareNet Patient Partner Research Council at one of our statewide convenings up in Vail. And then finally, PeachNet, as they were getting off the ground, they were just establishing their research advisory board, and this was a retreat that they had with them back in December of 2019. We've got a paper that's referenced here at the bottom of this slide about how we work with our patient and community advisory groups, and encourage you to check that out if that's of interest. As I mentioned, we also engage with other networks and other groups. So Metalark is that consortium of networks in different states and in Canada that we work with. We've done several projects with Metalark, one of which is just wrapping up, that was looking at what are the best ways to deliver advanced care planning in primary care. That was a PCORI funded project. We work with our practice innovation program partners here in the Department of Family Medicine. There's a fair amount of overlap between the practices that we work with across each of our programs and the practice innovation program. They've been great partners for the work that we do. I mentioned Accords, and Accords provides some of our core infrastructure funding, and we work with Accords in a variety of ways, including teaching in the primary care and outcomes research fellowships that Accords runs. CCTSI community engagement, we have some overlaps with them. As Cynthia mentioned at the top of the hour, I also direct community engagement for CCTSI, and that's been a great collaboration over the years, as well as we weave together the primary care and community sides of this work. American Academy of Family Physicians, they have a national research network that we also partner with. We're working with them right now on one of our opioid use disorder studies. That's a national study, and so we're working closely with them. We work with Colorado Academy of Family Physicians, our Colorado Family Medicine residencies as well, and you can see some of the logos there at the bottom of the slide. So what have we been up to? All this infrastructure, what's it good for? So we did an annual report, put this together and released it in March. And at that time, we were counting 23 active projects across 17 different funding sources. We like to have a diverse portfolio of funders. Over 23 million in currently funded projects, addressing 12 of our priority topics that we've gotten from our practices and community partners. And 15 of those 23 projects actually had involvement of community or patient advisory groups, which is really cool. You can see some of the national, federal level institutes and partners that have funded our work currently. And it's a long list, so that's really cool. So why should you think about partnering with us? Well, we like to think that we've got expertise in real world implementation science. We do a lot of that stuff. If you're interested in reaching out to broad and diverse populations, we can help you with that. If you want to just get out of the ivory tower and get some windshield time with us, that's also that's one of the things that I enjoy, hitting the road and visiting practices. And one of the things that we really encourage PIs that work with us is to come along for the ride. There's nothing like spending time in a practice, sitting down over lunch or something, talking with them about a project or what's going on with them. And, you know, I think this fourth bullet is really something that I think we can help with as well, to build the awareness and brand of our great cancer center here around the state. So that's something that I hope we can help with as well. As you're thinking about maybe working with this, here's some things to think about. So we like for folks to come talk to us early when, you know, that research idea might just be a glimmer or twinkle in your eye. Bringing that idea with our expertise about how to work with practices, that's oftentimes where the magic or the secret sauce is. So coming to us early with those ideas and talking to us about, gee, you know, do you think we could study this in one of your or more of your networks? We love those kind of conversations. And we also like to remind folks that when we're working with them, that to make sure that the funding also reflects the work. So that's where we try to build in funding for the Kristen Suitors, for other members of our field team that are going to be out there recruiting the practices for the study and also involved in implementing the study, that those folks are being funded and that there's some funding for our core infrastructure as well. I just can't emphasize enough how much our field team can be a real asset to your studies and projects in terms of how to actually work with and in practices and make use of them. Practice stipends, those are important. I would say that our practices don't really count necessarily on stipends to, push them over to engaging with us in a project, but they are important. We consider that as a little thank you on the top. And, depending on the size and involvement of the project, it might be, $1,000 for, a study that lasts a year. It might be, more than that for a study that's got more involvement that lasts longer. But those are things that we can help you with as you're building your budgets, and help kind of give you some comparisons of what we've used in other projects. Like I mentioned, we will always want to make sure that practices are benefiting from their participation in projects. This last bullet is I think sometimes flies under the radar a little bit, but we think it's a big benefit too of working with SNOCAP. If you're working with practices around the state and you're doing it under the auspices of SNOCAP, we have an active memorandum of understanding with Comer. So if a practice, in Ray, Colorado or Ridgway, Colorado, they don't have an IRB affiliation, Comer will extend coverage to them. So that's a big deal. And they've even helped us with designing, if the practice is actually going to be engaged in the research, they've designed community-based human subjects research training for folks out in communities, so they don't have to go through the brain damage of city training. So how do you partner with us? Well, schedule a meeting with me and or Mary when she gets back from maternity leave. But for starters, you can certainly reach out to me. Oftentimes, we like to have an initial conversation with folks. What's your idea? What are you thinking about? And then we'll encourage you to come present that at one of our monthly SNOCAP meetings. So that's a monthly meeting where our staff, our investigators come together, and we love to have folks come present their ideas to us so that we can kind of start that partnership and see how we could work together. You're always also welcome at one of our monthly meetings if you just want to check us out, see how this process works. Participating in a project, that's another way. We are starting to get back in the habit of running an annual convocation. That's another way to kind of get to know us. And then finally, signing up for our newsletter. I think there was a link in one of my previous slides, but I think the next slide may have a QR code that you can scan to get to our website. And there it is. So we'd love to hear from you. And I'm going to stop babbling and see if there are any questions.
I don't see any questions in the chat right now, Dr. Neese, but I was wondering how the pandemic affected the work of these outlying clinics and just the whole general pandemic nonsense.
Yeah, I didn't talk about that, did I? It was crazy. So when we were actually a couple of days away from traveling out to a practice in the Roaring Fork Valley when we all got put on lockdown. And we were about to start a project with them, and it was like, okay, we got to rethink this. One of the things that we did early on in the pandemic, and we actually continued this for some time, is we saw that one of the values that we could provide both to our practices, but also to folks here on campus and folks at the State Public Health Department, was to actually serially survey our practices to understand what they're struggling with.
Oh.
So we did a whole series of surveys during the pandemic to get at those kinds of questions, what their needs were, and then fed that information back out to practices and other partners Those things are actually those reports are actually on our website. So a lot of information about that. We had a bunch of studies that were in various stages that kind of some had to hit the pause button. We were just on the cusp of starting our PCORI opioid use disorder treatment study, and we actually negotiated with PCORI to add a third arm that was a telehealth arm. So we brought that into the mix for that study. Yeah, we got really creative.
Well, that's great. I did see that heading on your website, something about burnout, and I didn't look at everything in there, but we do have a question in chat now. I don't know, do you see them or do you want me to read it out loud?
I do see it. Yeah. So, hi, Netta. Has SNOCAP been involved in multi-center trials to include practices as spoke sites for a hub site? So we've done a little bit of that work, you know, and we've been involved in proposals around that. And, you know, I think that, again, the key thing there is how would a practice's involvement in that kind of a trial actually benefit them? So those are things that we, you know, would love to talk through with folks that are interested in doing that sort of thing. But yeah, there are opportunities to think about that.
Okay.
Yeah, thank you, Dawn. I will talk to you later more in detail. That was very useful. Yeah.
It's actually one thing that we've been interested in having some discussions around, you know, COVID related stuff. Well, so that's yeah, definitely something we're interested in.
Thank you.
It just sounds very, you know, worthwhile work. I mean, like you'd never run out of ideas, I don't think.
Yeah, we're definitely keeps us off the street. We keep busy, that's for sure.
Well, very worthwhile work. Any other questions? Those community groups that kind of advise, what were they called? Advisory groups or something?
Yeah, so we've got some that call themselves advisory councils. Our CareNet one, they recently rebranded themselves because they said, you know, we're more than just advisors, we're partners. So they renamed themselves the Patient Partners Research Council.
So I would imagine those would be very helpful, and they'd have a real pulse of the community. That
they often do. And, you know, I think what we're also seeing is frequently it's a real asset in a proposal when you can say that, you know, this is something that's been looked at by patients as well as practices, and in terms of, you know, interest and feasibility, that can be kind of huge.
Yes, I could see that. Well, you've given us a lot of information and a lot of food for thought. And anybody else have a question? If not, we'll let Dr. Neese go and back to his busy life.
Thanks, everyone, and let us hear from you.
Thank you. Bye-bye.
Bye-bye.